I'm Brittany Lewis with Forbes Breaking News. During a Senate Aging Committee hearing about mental health on Thursday, Senator Kirsten Gillibrand decried the rising threat of elder abuse. She specifically asked witnesses about the impact of racial discrimination, ageism, and COVID on mental health for the elderly. Here's more from the New York Democrat.
As well, Senator Braun with us at the hearing, and our next senator will be Senator Gillibrand, who's joining us virtually.
Thank you, Mr. Chairman. According to the National Center on Elder Abuse, approximately 1 in 10 older adults will become victims of elder abuse. Elder abuse has a physical, mental, and financial impact on older adults. A 2019 Centers for Disease Control Prevention report found that between 2002 and 2016, the non-fatal assault rate increased by 75.4% among men and 35.4% among women over the age of 60. And since 2020, crimes against older Asian American adults have become more prominent. This takes a toll on mental health. Racial discrimination and ageism can trigger chronic stress, anxiety, depression, and racial trauma. There's so much that needs to be done here, but funding for elder abuse and justice programs authorized under the Elder Abuse Prevention and Prosecution Act, Elder Justice Act, and the Older Americans Act is a first step. Dr. Emery Tiburcio, there we go. How does racial discrimination and ageism affect someone's mental health, and what are steps that we can take to effectively detect, prevent, and treat elder abuse?
Thank you so much for that question, Senator. So interestingly, ageism is what prevents many older adults from getting screened in the first place. We are not aware that older adults are using drugs. As Jim so eloquently pointed out, this is happening. In fact, I treated a 75-year-old gentleman who started using drugs at age of 75 after retirement because he was bored. And the idea that we don't think our ageist ideas prevent us from thinking about older adults using substances, or our ageist beliefs that depression is a normal part of aging, it's not, are what prevent screening, assessment, and treatment from happening. And in fact, there are so many older adults, Senator Gillibrand, as you were pointing out, around elder abuse that are in their homes, and we don't see them, and we are not coordinating care into those homes, and so those folks end up being abused and not having their needs met. And so the degree to which ageism impacts our screening, assessment, and treatment, it's also impacted by racism. In fact, African American and other Black and brown folks are not assessed, not treated, not offered treatment, even among Medicare beneficiaries. And so it is critical that we address these issues by universal screening for depression, anxiety, substance use at a minimum, that we train community-based organizations to interact with older adults, like Meals on Wheels and homemakers who are going into the homes and potentially seeing some of these issues, and making substance use services universally available. And we can also address ageism by increasing awareness of it. And to Senator Casey's point about increasing awareness of mental health and aging, increasing awareness of ageism even with our language, with frameworks like Reframing Aging from the Gerontological Society of America. So thank you for identifying not only mental health and substance use stigma, but also ageism in this space.
And as you know, because of COVID, we've seen so much more mental health needs grow exponentially. What are some of the barriers that our older adults are facing with regard to accessing mental health services? Are there ways we can improve utilization of existing services? And for older adults on Medicaid, how could enhancing federal Medicaid funds to incentivize states to provide better community-based mental health services address the gaps in utilization?
So access to services is an enormous issue, particularly for Medicare and Medicaid, in part because Medicare Advantage plans have been allowed to split physical health and behavioral health services. And as they do that, then those folks who are seen in primary care are not able to be treated by psychologists like me who are embedded in that primary care clinic. And so as Dr. Rogers pointed out, as each successive referral that older adults get, they're less likely to connect to those services. And so if Medicare Advantage plans and Medicaid plans that are commercially available were encouraged or required to have more integrated care, that would increase access. That warm handoff inside the primary care clinic goes a long way to be able to assist that older adult to access services. And providing services in the communities where older adults are. We hear this in our policy academies. We hear this in our community conversations, that folks trust people in their own community, whether we're talking rural Pennsylvania or we're talking urban Chicago, that people in their community are folks that they trust. And so creating those collaborations between faith-based organizations, between area agencies on aging and senior centers to be able to increase access from both a financial standpoint with increased access to those services, as well as the collaborations.
Thank you. Ms. Williams and Mr. Klassen, just two follow-up questions if there's still time. Ms. Williams, given your experience with Vibrant Emotional Health, what are the benefits with peer support programs and community-based mental health services? How has this approach helped reduce stigma and support older adults receiving behavioral health care? And Mr. Klassen, thank you so much for sharing your experiences. It takes extraordinary courage and is incredibly important to bring awareness to this issue. And if there's time, the chairman can tell me, because I can't see the clock, what are the key ways to reduce stigma, and what are some examples of coverage gaps that you've experienced?
Yeah, I'm also hard of hearing. I'm not sure I have the question, but what I would like to say, because it just touches on, well, you know, what's been shared here with Dr. Rogers and Senator Scott. So I train folks with mental health challenges to help people to become peer specialists, and thinking especially about the mobile crisis teams and being in, you know, working with law enforcement and all of that. I had one guy named Will that we had trained as a peer specialist, and he got a job for a major provider, struggled a bit with case notes and using the computer, didn't get fired, got transferred. I started to get a new set of phone calls from psychologists that was on this mobile crisis team that he was on. And the message there was, we don't know how we did it without him. Because of his lived experience and presence, he was able to de-escalate situations that professionals may have been, you know, challenged with.
Thank you. Ms. Williams, did you want to just answer the question that I asked you?
Thank you, Senator, for the question. Peer support has been incredibly powerful in terms of engaging older individuals that we serve and others in the community serve, in terms of destigmatizing access and being able to share their own stories of hope and recovery, and build trusting relationships with other older individuals and engage them effectively in care. I speak very highly of the use of integrating peer support with existing services, because it can effectively engage people in care and ensure that they get the treatment that they need.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Gillibrand. We're joined by Senator Kelly, and now we'll turn next to Senator Collins.
Thank you, Mr.